Good afternoon and welcome to the webinar on changes to Open Payments Rule. My name is Ned Mumtaz and I will be the host. I have Heidi Kocher who is going to provide most of the information on these changes to the Open Payments Act. I'm going to kick off with some quick house rules. So if I can go to the next slide, please. Okay. So first, all your lines are muted, but you are welcome to ask your questions through the panel on GoToWebinar. We will address the questions in the QA section in the end, and where possible, we will also try to answer your questions around the relevant topic of discussion. You are welcome to ask the question anytime. Important to explain and claim that the views and opinions expressed by the speakers are their own and do not reflect the official policy or position of the companies they represent, nor do the opinions and information expressed in any manner or form represent legal advice. This webinar will be recorded. The recordings would be made available after the webinar, and a copy of the presentation slides will also be sent to you. Please note that all the slides are copyrighted and may be used with attribution to the copyright holder. For anything related to webinar support, if you have any difficulty listening to the webinar or if there's any other issue with the audio or the visual of the webinar, please call 832-519-1365 or share any concerns through the chat box in the GoToWebinar. With that, I would like to introduce Heidi and her background and experience. So Heidi has 20 years of experience in healthcare, legal, and compliance-related issues. Her experience includes positions at large hospital corporations, serving as a compliance officer for Sleep Lab DME company, and as a compliance director, chief privacy officer, and interim chief compliance officer at a medical device manufacturer. Heidi has also represented and advised on critical access and long-term care hospitals, physician groups, home healthcare agencies, durable medical equipment companies, pharmacies, including compounding pharmacies, nonprofit organizations, and licensed individuals. In an acknowledgement of her experience, Heidi was recently appointed as a lecturer at the University of Texas in Dallas, their bioengineering department graduate program. I've had an opportunity to discuss and speak with Heidi about the topic at hand. I was extremely impressed with her depth of knowledge, as well as the manner in which she has shared, and she will share the information with you. I'm very excited about today's session. I have had an opportunity also to attend at least half a dozen conferences and a few webinars on the topic. And from my perspective, from my opinion, what you would get a chance to see today would represent a very comprehensive perspective on the changes that are coming, as well as some level of guidance and advice. Quickly about myself, so I'm an associate partner and practice leader at CoreData, life sciences practice. Before joining CoreData, I worked in the pharma industry and spent around 20 plus years working for Viat, Eisai, Otsuka, and Schering-Plough Pharmaceuticals. I have had an opportunity to discuss the compliance needs with over 150 drug and device manufacturers over the last few years. And I've had also an opportunity to participate in over a dozen webinars as well as conferences. So it's my pleasure, along with my co-speaker, Heidi Kocher, to present the topic today. With that, I'm going to ask Heidi to please share some of the background and take it away from here on changes that are coming up in the Sunshine Act. Heidi?
Thank you, Ned. I appreciate that very kind introduction. Okay, so I'm assuming that most of the people on the call have had at least a knowledge of what the term Open Payments or Sunshine Act is, but I'm going to go ahead and quickly give a bit of history. So this was originally part of the Affordable Care Act in 2010 as part of the law, and then CMS published rules in 2013. And so early 2013, data collection began in 2013 for fall, August of 2013 forward, and then was reported in 2014, and for 2014 and forward, there was just annual reporting. And so you gathered the data throughout the year, you reported it to CMS in March, and then after the background work that was done to validate all the information, the prior calendar year's payments are reported in July. And CMS has created a web page called Open Payments if anybody is curious in seeing what that is or knows what that is. I think we have a bit of an echo on the line. Maybe somebody could be muted. Okay, so let's look at the current reporting requirements, because I think it's very important to understand where we are currently to understand what the changes are that have been proposed. So as you know, we have applicable manufacturers who are pharma manufacturers and med device manufacturers, and they have to collect and report the data relating to covered products. Covered products for pharmaceuticals are defined by the NDC, and they're produced, propagated, prepared, compounded, or converted, those are the words used, in the United States. So this applies only to the United States. We should note that biologics, devices, and certain medical supplies are also covered, even though they do not have NDC numbers. You have covered recipients who, under the terms of the statute, were physicians and teaching hospitals, and that was written into the regulations. And the way we identified physicians was by their NPI number and at least one state license number. Teaching hospitals are those on a list that CMS publishes annually, so it's only those teaching hospitals that are on the list. And again, that is out on the Open Payments website. The reporting threshold, any item over $10 US in value, if the aggregated total for that individual is $100 or more. And these amounts are increased annually to address inflation. I have updated amounts on a subsequent slide. So what kinds of payments were we talking about? Not just payments, but also transfers of values. So we were talking about consulting fees, compensation for services other than consulting, speaking fees, and so on, honoraria for speaking, gifts. This would be promotional items like mugs or ball caps or banners, handouts, all kinds of things that are promotional, but that have not just marketing materials, but actually have another use. Entertainment, so this would be attendance to or tickets to any sports, recreational, cultural, or other events. Food and beverage, this is one of the biggest ones. This is any food or beverage provided to a physician or a teaching hospital, and this includes meals that were in the healthcare providers' offices, such as when as reps come in to do a lunch and learn. Travel and lodging, if you are bringing people to a conference or to the company's locations, any travel and lodging must be reported. Education, that's pretty straightforward. Research payments, that's pretty straightforward as well. You also had to report charitable contributions, and again, these are any payments or values made to a tax-exempt organization. A charitable contribution is by definition to a tax-exempt organization. So examples here would be donations to fund a wing at a teaching hospital, donations to a nonprofit like the American Heart Association. Royalties or licenses. current or prospective ownership interest. This would be, for example, shares held in a company. Now note that for ownership interest, you also have to report those held by the immediate family members of the physician. So this is an important step beyond just reporting for the physicians. You had to report compensation for serving as a faculty or speaker at an accredited continuing ed program, and there was a separate category also for serving as faculty or speaker at an unaccredited continuing ed program. So again, those would be things that aren't done through the graduate, the GME, for example, or another accrediting organization. You had to report grants to fund research, for example. Grants are different from charitable organizations in that a grant can go to a for-profit company or something that isn't a nonprofit. You had to report space rental and facility fees as well. So this was the category of payments that we've been working with up to this point. One of the important things that you had in the original Sunshine Act was what is called the preemption provision. And this essentially said, well, let me back up a step. One of the issues previously was that when there was not a lot of transparency going on, a number of states began enacting their own reporting laws. And so you had this patchwork of reporting laws across the United States. So the original act basically said we are preempting these state reporting laws to the extent that they cover the information that's in the federal Sunshine Act. We do not preempt them if they go beyond the federal laws. So here on the second bullet point, this is just a partial, this is not a complete list of states and localities that have their own reporting laws. And what I think is important to note here is not only do you have state reporting laws, but you can see that we had, go back a slide, that you have counties, Miami-Dade County, and a city, Chicago, enacted its own reporting laws. So some of the ways that these lists or these state laws differed is they, for example, may have had expanded lists of covered recipients. Remember, the original Sunshine Law was just physicians and teaching hospitals. So Vermont, you had residents, nurse practitioners, PAs, pharmacists, and employees of prescribers. Massachusetts included residents, PAs, nurse practitioners, pharmacists, and nursing homes. Minnesota had residents and PAs, but not pharmacists, employees of prescribers, and not nursing homes. Washington, D.C. had all licensed healthcare providers, including, for example, registered dietitians, radiology techs, and so on, occupational therapists, and so on, and all licensed healthcare facilities. So you can see that even though you have this preemption provision, there's still a lot of variability at the state level. Some states also had expanded lists of covered products. So Vermont included samples, including over-the-counter drugs and devices, coupons, vouchers, patient starter kits, demo devices, anatomical models, and accredited CME. Massachusetts required reporting of accredited CME and anatomical models. Washington, D.C. required reporting print and media advertising costs for advertising that was done within D.C. itself. West Virginia required the reporting of national and print advertising. So you see here, again, just all kinds of different kinds of payments. And some states had other limitations. So Vermont had a total ban on food provided to the prescriber if the prescriber, quote unquote, regularly practiced in Vermont. Massachusetts had a requirement or a specific provision that, quote unquote, modest meals outside of the office are allowed. So you could hold an event, let's say at a restaurant, and provide a meal, but the meal had to be modest. Minnesota actually had a $50 limit on meals and physician education per prescriber per year. And West Virginia basically said you don't need to report unless you aggregate to $100 per recipient annually. So still a whole lot of variability out there at the state level in terms of what is to be reported. So how did this work? So again, because of all these preemption provisions, and you see that the different variation among the states, what became clear was there was still some ways that we could expand sort of the federal scope of the law and preempt the variety of state laws. And so this became part of the Support Act, which was signed by President Trump last October. This was actually intended to be part of the opioid legislation that was signed last year. The Support Act really deals more with opioid abuse and dealing with that crisis. But as part of this, they released new regulations at the end of July, and they were published August 14th in the Federal Register, and these new regs are part of the annual physician fee schedule update. So what they have done with these new rules is they have expanded the list of covered recipients, which remember previously was just physicians and teaching hospitals, and now we include a number of mid-level, most of the mid-level practitioners, physician's assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists, and certified nurse midwives. Why did we expand to these individuals? Well, these are individuals who usually have prescriptive authority under state laws. Not every licensed professional has prescriptive authority. These ones do, which means they could prescribe pharmaceuticals or devices as far as it's permitted in the scope of their state licensing laws. So that means that pharmaceutical companies and med device companies might be approaching these individuals as well to convince them to prescribe their drugs or their devices. So what we have here with this expanded list of covered recipients is we're sort of expanding, as I said, the preemption, the federal preemption compared to what was previously. But again, we don't eliminate the state law issues entirely, and I want to make clear that if you're doing this, you really need to make sure that you still look at the particular state, because again, there are aspects of the particular state reporting laws that haven't been addressed by this preemption and these updated laws. So moving ahead, so where are we? Well, for one, we have tweaked the reporting threshold. As I mentioned earlier, the threshold for reporting is increased by inflation. So for 2019, you had the individual payment or transfer of value pegged to $10.79. And the aggregate threshold for reporting in 2019 is $107.91. For 2020, that has increased, and so you will have $10.97 for individual payments and $109.69 for the aggregate total in order to be reporting going forward. Okay, let's talk about some new covered payment types as well. These were also in the rule that was published in August. So we have 3 new covered payment types called acquisitions, debt forgiveness, and long-term medical device or supply loan. And to some extent, these aren't really so much new categories of payments, but refinements of existing payments. And you'll see that as I get into the discussion about these. The new rule also consolidated the 2 categories of payments for serving as faculty at a continuing education event. You remember previously it was a category for accredited continuing education, and then you had a separate payment category for non-accredited continuing education program. So these have now been lumped into one category simply for serving as a faculty at a medical education program. So those folks who were tearing their hair out about figuring out whether something was accredited or non-accredited, that step has at least been made a little bit easier. So acquisitions. This is a new payment type, and basically what it is used for is buyout payments made to covered recipients when the pharma manufacturer or the device manufacturer is purchasing a company where the covered recipient has an ownership interest. So remember, you're supposed to be reporting an ownership interest. And now when you're selling that company, there's a category for acquisitions. So for any given ownership interest, this will be reported, I presume, only once when that actual purchase is made. So that's pretty straightforward. The rule doesn't specify exactly what date to use, but the date I would use as to when this is triggered is the effective date of the transaction. And usually when you have a business transaction, payment is made on the same day as there is a bill of sale or you finalize the transaction, what's known as closing date. So that is the date that I would use unless there is additional rules coming out. And we do have transactions where obviously a payment is paid out over time. We need to wait and see if CMS is going to take a different approach and say that as you make payments over time, you need to report those over time, or if you simply report them at the closing date. At this point, I would say that it's probably the closing date. But that's one of those factors that we still need to see and probably requires some additional rulemaking. The other category of payment is debt forgiveness. And again, this relates to an ownership or investment interest. And this is the forgiveness of the debt of a covered recipient, a physician owner, or an immediate family member of the physician. So if a company extends a loan to a physician owner or a family member and then subsequently forgives that debt, that must be reported. The interesting thing about this payment category was these forgiveness of debts were required to be reported under the open payment system all along. But there hadn't been a specific category for reporting this. So I'm not quite sure where people actually reported this, perhaps under a gift. But obviously, so this is, that was a problem. So this is more just sort of a fix of a problem in the terms of the reporting.
So Heidi, this is Ned. I have a quick question on that. So on the previous slide, with respect to debt forgiveness, is there a difference between uncollectible debt versus debt forgiveness with respect to reporting the two?
That is an excellent question. It is not clear from the rules exactly if they have thought that far in advance, but in my opinion, uncollectible debt is different from actual forgiveness because uncollectible debt is sort of sitting out there until you make the decision not to collect it. So once you make the decision and you tell somebody you're going to forgive that debt, I think that's the trigger point of it becoming reportable. I mean, it's like when you have, accounts that go to a collection agency. I mean, just because it goes to a collection agency doesn't mean that it has been forgiven, and a collection agency may make multiple attempts to collect the debt before there is a decision made that it is uncollectible. And then there has to be an additional step taken before it becomes a debt forgiveness. So you might be looking at something like a settlement agreement or a waiver or some other specific notification that forgiveness of the debt has occurred.
Thank you. So as I grasp the three aspects, which is short-term loaner device, long-term loaner device, and a situation where the device is never collected, I'm using device as an example, then from a process standpoint, manufacturers will need to start to almost track any time any loaner devices are offered to determine in which of the three categories those would go. So in the scenario that it is not considered not considered as debt forgiveness, but is still a weighted collection for device, in that case, that device will have to be reported for the long-term over 90-day loaner. And then at some point when there is a judgment made that they would not be collecting it back, then to your point, a decision will need to be made whether they would pursue collection or not. And if not, then it goes under debt forgiveness. So appreciate that. I think
Well,
that, go ahead, please.
actually, let me clarify a little bit. Debt forgiveness only relates to an ownership or investment interest and not a loaner device. So I think this is more like ownership in a company or in something else. There are different categories for loaner devices, and my next slide is actually going to talk about that. But I do think you have a good point that if you have a loaner device and it's out there for a long time, at some point you're going to realize you're not getting it back, and how do you report that? I think that's still something of an open question, because you have to report in different categories. And remember, we had previously the category for a short-term loan. So you've already reported the value under short-term loan. And I'm actually going to advance the slide because you've sort of anticipated my next category, which is another payment category, a new payment category for a long-term device or loan. So again, remember, the existing category is 90 days or less. The new category is for 91 days or more. But you're right that this simply anticipates a loan, and a loan, of course, means that you're supposed to get the device or item back at some point. What happens if you don't get the item back? And I think it is very much an open question if that is a reportable event. How do you calculate the value, and then what category do you report it under? Does it become a gift at that point? Do you account for depreciation? Some devices or supplies can be used up. How do you calculate that? I think is very much still an open question, and it's not addressed in any of the materials that I have seen. So you're right. This is something to be thinking about.
Thank you. Thanks for that clarification. So I misunderstood the debt forgiveness. I was presuming that also applied to devices or loaner devices. And to your point, I have seen manufacturers report devices that they could not recover under gift in the past. But let's see how organizations formulate their business policy around these. Thanks for that clarification.
Right. No worries. Okay, so we talked about that. So let's talk about some of the new covered recipient types. Again, so what they did is in the Support Act, they referred back to the definitions in the Social Security Act for physician's assistant, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists, and certified nurse midwives. So one of the things that I did is kind of went and checked to see approximately how many people there are in these different categories. And you can see we put the table on the right-hand side. So we're looking at approximately 560,000-ish potential new covered recipients. Now, I do want to point out that there's a very interesting distinction here. For these mid-level practitioners, med device and pharma companies do not need to report ownership interest. You only need to report payments and transfers of value. So again, meals, travel, lodging, continuing education events, all of those other things, but you don't need to report ownership interest. So Ned, your comment about, forgiveness, that pulls into question, and I don't think people thought through this. If you're not reporting ownership interest, then you're not reporting acquisition, and you're probably not reporting debt forgiveness as well, because again, that relates to sort of an ownership interest. So very interesting to see how some of this shakes out and what the data will look like going forward. I do want to make sure that we have a new term now, because you have the physicians plus all these individual covered recipients. They are introducing a new term. We now have, again, teaching hospitals and non-teaching hospital covered recipients. So everybody who is a person or an individual is going to become a non-teaching hospital covered recipient. What a mouthful. So let's look at these in a little bit more detail. So the definition of a PA is, again, in the statute there. There's approximately 160,000 PAs in the United States. And these have to be individuals licensed in the state where the services are performed. So one of the issues that you have going forward is you're going to need to verify licensure in that state by obtaining the license number. Now, part of the problem is that PAs are licensed by a whole variety of different entities. Physicians are typically licensed by the medical board, but as you can see here, a PA may be licensed by the state medical board, the state board for osteopathic physicians, a separate board for physician assistants, the Department of Health or Healing Arts, or a Department of Licensure and Regulation. So we have now sort of increased the scope and complexity for verifying PA licensure. Note that PAs must also be certified by the National Commission on Certification of Physician Assistants, and you've got your certification denoted by a PA-C. So as you are figuring out who is a physician assistant, the complexity has increased because, again, you need to figure out what is the licensing entity of the particular state, and you're going to need to verify if the physician, the PA, has been certified. So you're going to need to check that they have the PA-C or verify some certification and the licensure. For a nurse practitioner, we have similar issues. There are approximately 270,000 NPs in the United States, and again, they're licensed in the state where the services are performed, so you need to verify their licensure. Now, a nurse practitioner is typically licensed by the State Board of Nursing or nurse examiners, but they have separate databases often for standard RNs, for LVNs, and for advanced practice nurses. So you need to make sure you're finding the right database. I'm actually based in Texas, and when you search for an NP in the regular RN database, you don't find that individual. You have to make sure you're looking in the APRN database, the Advanced Practice Registered Nurse database. So to become a nurse practitioner, it requires graduate education. So we're not talking somebody who has an associate's degree or even a bachelor's degree. They typically, well, they will have either a master's or a PhD. They can be certified in a specialty. So you have geriatrics, family medicine, psychiatry, pediatrics, etc. We have two large certification boards in the United States. They're the American Academy of Nurse Practitioners and the American Nurses Credentialing Center. And what we are moving towards is a trend to do national regulation and licensing standards for the four largest advanced practice nurse roles: the certified nurse practitioner, a CRNA, a clinical nurse specialist, and a certified nurse midwife. And of course, these are the four mid-level nursing roles that are captured by these new regulations. So hopefully we'll keep on moving on the trend for this, because I think that would make everybody's lives a whole lot easier. A clinical nurse specialist We have approximately 72,000 of those in the United States. And again, you need to go to the individual state where the services are being performed, and you need to verify licensure in their state. Typically, the clinical nurse specialist will show up again in the APRN, Advanced Practice Registered Nurse databases. And these individuals, they require, again, a master's degree in a clinical area of nursing from an accredited an accredited educational institution. CRNAs, we have approximately 54,000 of those. Again, you need the state licensure, and now you need a specific nurse anesthesia education program. And these are typically established by the Council on Certification of Nurse Anesthetists. So again, part of the problem is you're not just dealing with licensure, but you need to validate the certification as well by going to validation of a national certification program. Certified nurse midwife, we have approximately 11,500 of those in the United States. Again, you need a master's or doctoral degree, and this one has to be specifically in nurse midwifery. Again, you're going to be licensed as an APRN in the state where your services are performed. There is a special certification board for the, it's called the American Nurse Midwifery Board or Midwifery Board. The thing with nurse midwives is to be aware that you may have, again, a separate entity who is licensing. So, for example, Utah actually has a separate board of nurse midwifery/midwifery, and that is different and distinct from the registered nurse certification and board. So if you're looking for a certified nurse midwife, you're going to need to verify them in this database, and they may or may not appear in the regular nursing database. You should be aware that licensure may also occur through the Department of Health in a particular state. The thing that is tricky here is that some states permit non-RNs to be licensed as midwives, not nurse midwives. That's a mouthful there. So for example, Texas actually permits midwives who are not nurses, and they are licensed by the Texas Department of Licensing and Regulation. So I think for these advanced practice nurse types of roles, we're going to go through a period, and companies are really going to have to spend a lot of time figuring out which is the appropriate licensing agency and how do we validate and verify that any given individual is both licensed and certified. So I think that is going to be some work to be done in the next year or so.
So
so typical in our, go ahead.
There are a couple of questions that have come up with regards to various certifications and various nurse practitioners as well as physician assistants. The first question is about whether there is a national database that can provide information on PAs and their certification. Do you know if there is such a national database available?
I did not verify this. I am not clear if the National Commission on Certification of Physician Assistants actually has a publicly available database. I can verify that afterwards, and we can send that out to the attendees.
Okay, thank you. One more question that came in relates to dental assistants and dental hygienists. Are they added to this list of covered recipients that would be reportable, or what you classified as non-teaching hospital covered recipients that would be reportable starting 2021?
That is an excellent question. At this point, dental hygienists and any advanced practice individuals are not covered under this point.
Okay.
Remember that dentists are included under the definition of physicians, but hygienists have not been included this. Stay tuned. We may see next year an updated rule when CMS realizes that they left out dental hygienists. But
Okay.
at this point, they are not.
All right. Thank you. Thanks for answering those questions.
No problem. So typical interactions that you're going to be seeing with these new types of covered recipients are, of course, meals. The big one is obviously providing food during an educational session in a physician's office or an ambulatory surgery center, for example. Gifts. Education, of course, is going to be a big one. So if somebody is provided education, sponsorship to, for example, an industry event or any other kind of education, charitable contributions, space rental. I point out the space rental. I'm sure some people are scratching their heads going, how can somebody have space rental? In a number of states, nurse practitioners are permitted to have their own entity. So for here in Texas, for example, a nurse practitioner can open up a practice, and as long as she has an agreement with a supervising physician, a nurse practitioner can actually run a clinic, and we see a lot of those here in Texas, particularly for psychiatric issues or for pediatric issues, where nurse practitioners actually run their own practices. So in those circumstances, if somebody is working with a nurse practitioner and maybe, leasing space in their offices, you would have space rental as an issue. Some of the things, again, remember, we're not going to be reporting ownership, so everything pretty much other than ownership is fair game, but I think these are going to be the big ones. We've got, just so people can understand some of the issues here, we have some sample scenarios on verifying an individual's information. And this is information that Ned has actually come across and a problem that he's faced. So Ned, do you want to take over?
Sure, Heidi, thank you. So for the listeners, what I went through was with my team that assembles today some of the transparency reporting capabilities for our clients, and I wanted to understand from their standpoint what some of the challenges one might anticipate, given the question that came in earlier. And again, my research and my colleagues' research have shown that there is no sort of national registry available that has all these mid-level practitioners and their credentials available. Most of these credentials are available at the state level. So I have played out a quick scenario to sort of highlight some of the challenges industry would have in accommodating nearly 500,000 additional covered recipients that you'll need to capture, and I have a couple of suggestions around it. So let's play out the scenario. Here is an example. You have received the sign-in sheet. The sign-in sheet has the first line written down. The name is, the first name is not very clear. The second name, probably Metcalf. The place where this event took place was Pennsylvania, Philadelphia. And then there is a handwritten license number. But without knowing the state where this license number is from, you would not be able to, in the absence of a national registry, verify who this individual is. A second scenario where this time the name is clearly spelled out and written, Heidi Metcalf. She's a physician assistant licensed in Texas. And then there is a license number. So in these two scenarios, what's expected from manufacturers in order to A, aggregate the information, and B, find out and verify the information. I will cover that shortly. Maybe I'll cover it now. So let's go to the next slide. Who is she, and what steps would one need to take to verify? So if you know the state and if you know the name, many of the state registries have a search mechanism available where you can put in the full name and find who the practitioner is, and also find their license number. So it turns out that Heidi Metcalf is a physician assistant, and her license number is PA04265. But without knowing the fact that she is licensed in Texas, if you were to go and try to find Heidi Metcalf, you would not have much luck. I want to give you a couple more examples and then return the conversation back to Heidi's rest of the slides. So here are some other examples that my colleagues had assembled. So let's say you got the name Heidi Metcalf. She's a physician assistant, Texas, and a full license number. In this case, the minimum obligation you may have would be to verify that whether this license number is accurate. If you only have first name, if she signed an H Metcalf and she did put down that she's licensed in Texas, then you'll have to go through the effort of finding her. Now, some state search mechanisms allow for wildcards, so you can type in H star Metcalf and you might find the person. In other cases, you may not. So this is an example of a find and verify. Maybe I'll cover one more scenario, which is the fourth one. You have Heidi M, PA, and that's all she wrote before she attended the speaker program. In that case, I feel you won't be able to find that information unless you start to assemble your own internal database of physician assistants, of mid-level practitioners that you work with, and then you might have a shot at collecting that information. So at the minimum, guidance is that you'll have to rethink and readjust your processes for capturing information. When compared to physicians, where there are several comprehensive national databases now available, this is starting at ground level one again. And just to show you, if all you had was a Heidi M, you would be able to find, you'll have a shot at finding that if you were to look for someone in Texas. So I did that search. I typed in first name Heidi, last name M star for wildcard, and I did find Heidi Metcalf, physician assistant, but it returned me top 16 records that matched that criteria. So if Heidi Metcalf did not make it to the top 16, I would not be able to find her information with just partial last name. So suffice it to say that you may have to tighten up your data collection or data recording processes in order to start to handle 500,000 or so new recipients that are showing up. And the last advice I would say or suggest is that you may want to start the process a few months earlier than you are required from a regulatory standpoint. Heidi, any comments or feedback from your standpoint?
Boy, I agree with you wholeheartedly. I think the listeners on this webinar should be starting this afternoon to try to figure out exactly how you figure out where these individuals are licensed and how to get at them. And you need to look, again, at a state by state level. And there's just so many variables in particular circumstances at the state level that it's going to take people time to do this, because not only do you have to figure out where this data is, then you have to build it into your systems and your processes. So this is absolutely critical that they start looking into this immediately. I could not agree more.
Thank you. Back to you, Heidi.
All right. So now that we've seen some of the problems that we have in terms of finding who these people are, we've also got new identifiers coming. So one of the issues has been that drugs have an NDC, but we don't have a similar identifier, unique identifier for devices and supplies. So FDA already requires a UDI, and the proposal is that you use that UDI for a particular product. The problem is that you may have multiple UDIs for different variations on a product. So small, medium, and large each may have a different UDI. Green, blue, and red each may have a different UDI. So that's kind of a problem that still has to be resolved. As a bit of background, the UDI is developed by one of 3 FDA accredited issuing agencies. And depending on the agency, they create a UDI with different portions. The DI, device identifier, is a mandatory fixed part of the UDI, and depending on which accrediting agency you use, that DI can be from 7 to 24 characters long. So again, as you are setting up your processes in your internal fields, you need to make sure that you can accommodate a DI up to 24 characters that's alphanumeric. Note that the DI does not include lot or batch number, serial number, expiration date, manufacture date, or the distinct ID code that's required for human cell, tissue cell, or cellular and tissue-based products that are regulated as devices. So I think there's going to have to be some work done with that as well to figure out what you're going to be using as a device identifier. So our suggestion is that you pick a default DI, the device identifier, perhaps the base model, where you have different options or sizes. And again, that's something that companies are going to have to work out internally. You should be aware that the DIs that are placed on packaging materials should be the same DIs that are reported to the open payment system. This, I think, is a potential avenue for double checking and enforcement further on once they have a couple of years of data. One important thing to note, the UDI and the DI is not the same thing as the Universal Product Code, the UPC, or the barcode. So this is, I think, going to throw yet another element of complexity into figuring out how you are going to be reporting this information. So again, now we only had national drug codes at the time of the original rule for drugs and biologicals, and those were ones that were out in the marketplace. Just remember that the NDC is required for drugs and biologics in both research and non-research contexts. So again, you need to be tracking all of that data. Relevant dates. So again, the data for these new categories is to be started collecting in 2021, and reporting is to be in 2022. So take this coming year, we've got a year and a couple of months left to start figuring out how to gather this data and figure out these processes. Take that time, use it wisely. One thing to note, the NPI of physicians and some nurse practitioners will also be publicly reported beginning in 2022. So to the extent that you collect but don't report the NPI, kudos to you. If you are not collecting NPIs yet, you need to work those into your processes as well, because this is now also reportable information. So again, cannot emphasize too much. You need to use this next year to figure out how to gather and validate all of this information that will be reportable coming in 2022. Penalties. Of course, the statute and the regs have penalty for a failure excuse me, to provide complete, accurate, and timely information. These are civil monetary penalties. The minimum penalty for an accidental failure to provide information is $1,000. It's not more than $10,000 for each payment or transfer of value that was reported. And the accidental failure to report penalties are capped at $150,000 per year. Knowing and deliberate failure to report or submit data is a penalty of at least $10,000 for each payment or transfer of value. And the knowing failure to report, those penalties are capped at $1 million per year. An important element in this, documentation in this information in this context is very important. You have to retain the documents for at least 5 years from the date of publication on CMS's website. So this looks like you're retaining the documents in some cases likely close to 6, maybe 6.5 years. So you need to make sure that your documentation retention is correct, because if CMS comes back and asks you and you cannot provide the documentation, you are going to be looking at a failure to report penalty. So you want to make sure that you have that documentation captured and handy as well.
So Heidi, one quick question related
Sure.
to the penalties. So what you're saying is, in the example we played earlier, if one fails to find, in that example, Heidi Metcalf, and therefore fails to report that transfer of value that she received, that would subject the manufacturer to a possible penalty of between $1,000 to $10,000 for each such instance. Is that correct?
Well, it's not clear at this point if that is an accidental failure to report. I think this is more on the lines of a knowing failure to report, because you know there was a transfer of value, you know you have an individual, and you simply haven't taken sufficient steps to validate the information. So I think if you had the information on Heidi Metcalf and you failed to report her, you're actually placing yourself in the category of a knowing failure to report, which triggers a minimum penalty of $10,000.
And these capped amounts of $150,000 per year and $1 million per year are capped at the manufacturer level, correct? So that's
correct.
That's capped per manufacturer. Okay, thank you for
yes,
that.
Yes,
appreciate it.
Yeah. That is our presentation. Do we have any questions?
So participants, you have a couple more minutes. I had a chance to review the presentation just before the webinar, and I felt that this was the most comprehensive summary of the changes as well as guidance, including this was the first time I had an appreciation of the count of mid-level practitioners that are getting added to the list of covered recipients. So you have a couple more minutes. If you have any questions, this is your opportunity to ask those. If you think of questions a little later, you still have an opportunity to send those questions into the host's email address, and we will try to assemble those questions and provide the answers back. I did receive 1 or 2 questions around the copy of the presentation, and yes, that would be distributed to the participants. Just reminding all of you about the copyright aspect of the presentation, but yes, you will receive a copy of today's webinar presentation. If there are no more questions, again, I want to acknowledge and thank Heidi for putting together an excellent, comprehensive, and very pragmatic guidance to the rules and the changes that are coming up. And with that, I would like to give Heidi an opportunity to say a couple of words before we close out the webinar.
Thank you very much, Ned. I think the one thing that I probably cannot emphasize too much is that having been in-house and done this, setting up an open payment sunshine transparency program myself, I know how difficult it was to validate physician information, because each state had 1 or 2 options if you had an osteopath, for example, or a straight medical board. But I think with the nurses, this is just becoming even more complex. And again, I cannot repeat myself too much. Take the time that you have now and make sure you know where these licensure records are. the state level nursing licensure records are unfortunately much more scattered and much more complex than physician licensure records. And I think companies really need to invest time and effort in ensuring that they get this data right. I'm very much looking forward to see the data that is published in 2022, because it will be interesting to see if there's a huge jump in the data in terms of transfers of value and payments to these mid-level practitioners. PAs, I can see. Nurses, I'm not so sure how much utility there is in that data, but I guess we shall see once it comes out.
Excellent. Great points. Completely agree. Can't agree more about the practical challenges of aggregating, identifying, and then providing the reporting. So with that, participants, again, thank you for attending today's webinar. Heidi, again, thank you so much for providing very comprehensive guidance to the participants. I would like to close out the webinar. And again, if there are more questions, please feel free to send those in. We will try to address them. Thank you and take care.
Thank you all. Bye-bye.